Today, we're going to give an update on cellular therapies and stem cell transplant from ASH. The session will be moderated by myself and Dr. Lohith Gowda and Dr. Stuart Seropian, who's our director of the stem cell transplant program and co-director of the cellular therapy program, has also joined us and will help moderate the session together with Lohith and myself. So we will get started. The first half of the talk will give some updates on CAR T-cell therapy for hematologic malignancies. So I'm going to go ahead and get started. So thank you again for joining, everyone. We'll probably leave the questions for the end. These are my disclosures. And just to give everyone a little bit of a background, today I'm just going to show a general schematic for CAR T cells. So as you know, CAR T cell therapy has been approved in the last 5 years to treat patients with hematologic malignancies. The T cells are genetically modified to target tumor cells, and this can be done in the absence of MHC1 and 2 expression on the surface of the tumor cells. So there's a targeting domain that binds to the antigen on the cell surface. There's a linker, and then there's a co-stimulatory domain that gives these CAR T cells proliferative capacity, and a T cell activation domain. So we have currently multiple FDA-approved CAR T cell therapies. It's hard to believe. The majority of them are approved in the setting of B-cell lymphoma. So we have 4 products currently: axicabtagene ciloleucel, brexucabtagene autoleucel, lisocabtagene maraleucel, and tisagenlecleucel. And they're currently approved for patients with relapsed refractory B-cell lymphoma after at least 2 lines of systemic therapy. Brexucabtagene was recently approved in patients with mantle cell lymphoma, as well as in adults with relapsed refractory B-cell ALL. So these are 2 more recent approvals. And then in the multiple myeloma arena, the target is BCMA. And I'm happy to say that we not only have idacabtagene viclucel approved in patients with who have failed at least 4 lines of prior therapy, but very recently there's a new approval of ciltacabtagene autoleucel in the same refractory patient population. So this is the summary of the efficacy after 2 lines of therapy for the currently approved products. As you can see, there are very high overall response rates from the 3 randomized phase 3 trials. Complete response rates vary anywhere between 40 to 58%. And you can see that at 2 years, about 40% of patients, there's a 40% progression-free survival basically at 2 years, which is definitely not bad for refractory patient population that otherwise would have expected very poor outcomes. The toxicities, as you are familiar with by now, are twofold: cytokine release syndrome and neurologic toxicity, which happens in the majority of patients. However, grade 3 to 4 CRS and neurologic toxicity, fortunately, are less common, and there's some variability between the products in terms of the grades and severity of CRS and neurologic toxicity. So what was exciting at this year's ASH was that there have been efforts made to move these CAR T-cell therapies further upfront in the treatment of patients with lymphoma. And, the question arose, well, given that this type of therapy is doing so well in the relapse refractory setting, could it potentially replace autologous stem cell transplant? So there were 3 studies that were presented and are currently published, and those were ZUMA-7 with axicabtagene ciloleucel, Belinda with tisagenlecleucel, and the Transform study with lisocabtagene maraleucel. And they looked at high-risk diffuse large B-cell lymphoma patients that were either refractory to first-line treatment, which is usually R-CHOP, or that relapsed early after first-line treatment. And the patients were randomized to either CAR T-cell therapy or the standard of care, which is salvage therapy with autologous stem cell transplant. So I will start with ZUMA-7. Basically, this is, again, an autologous second-generation CD19-directed CAR T-cell therapy that's currently approved after 2 lines of therapy. And in the study design is that patients had relapsed refractory disease within 12 months of adequate first-line chemoimmunotherapy, and that were intended to proceed to autologous stem cell transplant. So they were stratified by first-line treatment response and second-line age-adjusted IPI. They were randomized to axi-cel, 2 × 10⁶ CAR T cells per kg, after receiving some lymphodepleting chemotherapy with fludarabine and Cytoxan, or the standard of care, which was 2 to 3 cycles of investigator-selected, usually platinum-based chemotherapy, because that's what we use in practice, either RICE or RDAP. Patients that achieved either complete or partial response went on to receive a stem cell transplant, whereas patients that did not achieve a CR or PR were off protocol. And this is important, as you'll see, in a distinction with the Belinda trial. The ZUMA-7 study did not allow for any bridging therapy prior to CAR T, and there was no crossover. So patients who did not respond and could not go on to transplant did not cross over to the axi-cel arm. Some of them, actually 56%, did receive subsequent cellular immunotherapy, but that was not done on trial. So, what happened to these patients? Well, you see that they enrolled 359, 180 received axi-cel, actually were randomized to axi-cel, 179 to standard of care. And then when you look at what happened to them, out of 180, 178 underwent leukapheresis, 172 received lymphodepletion chemotherapy, and 170 received axi-cel infusion. So 94% of the starting patients actually received axi-cel, which they were randomized to. Whereas in the standard of care arm, out of 179 patients, only about 64 of them received stem cell transplant, which is 36% of patients. And this actually is not uncommon in clinical practice, because many of these patients end up, for one reason or another, not responding to the salvage chemotherapy, or they develop organ toxicity. They may not have, by that point, they're lymphodepleted, so they may not have fit T cells. They may not have fit stem cells for us to be able to collect. So a minority actually made it to transplant. So when we look at the baseline characteristics, they were pretty well distributed among the groups. As you can see, 74% of patients were primary refractory, and then 26% of patients had relapsed within 12 months. There were some high-grade B-cell lymphomas, including double and triple hit, 17%, dual overexpressors, and MYC-rearranged patients. So when we look at the event-free survival, which was their primary endpoint for the study, you can see that the 24-month event-free survival was 40.5% in the axi-cel arm, compared to only 16.3% in the standard of care arm. And that was actually true when they looked at each of the individual subgroups by age, response to first-line therapy, and whether they had high-grade B-cell lymphoma, including double, triple hit, or double expressor lymphoma. And when you look at the complete response rates, so overall response was 83% in the axi-cel arm, and 50% in standard of care, and complete remission rates were 65 versus 32%. So there is some confounding in terms of looking at the overall survival benefits, because as I mentioned earlier, 56% of patients in the standard of care arm received subsequent cellular immunotherapy off protocol. So this is the event-free survival curve here, again showing a dramatic improvement. Median event-free survival 2 months versus 8.3 months in the Axi-cel arm. The hazard ratio favored Axi-cel for all of the different subgroups, including really high-risk disease. Again, this is reflected in the progression-free survival curves that separated. And then when you look at the median overall survival was 35 months in the standard of care arm, and it was not reached in the Axi-cel arm. And you know, it's going to, again, to be difficult to see curves here that in terms of overall survival that are dramatically different from each other. So again, nearly 3 times more patients that were randomized to Axi-cel received definitive therapy versus standard of care. And there was a significant improvement in event-free survival and response rate compared to standard of care. So this ZUMA-7 may actually mark a paradigm shift where Axi-cel should be considered the new standard of care for patients with second-line relapse refractory large B-cell lymphoma. This is the TRANSFORM study. So it looked at lisocabtagene maraleucel. I will not go into a lot of detail because it's very similar, but I just want to point out that this CAR T-cell therapy is slightly different from Axi-cel because there's a defined composition of CD8 and CD4 T-cell components that are expanded separately, and then they're administered to the patient in equal target dosing. So when we looked at the study design, it's very similar. This did allow some bridging therapy, but then they performed a PET scan prior to lymphodepletion and lysocell. And if there was no response by 9 weeks or progression at any time, crossover to the lysocell arm was allowed. So when you look at the event-free survival, again, with a median follow-up of 6 months, there was a significant improvement in event-free survival of 63.3% compared to 33.4% at 6 months. And that continued to hold at 12 months, even though there was some decline. So 44.5% versus 23.7%. Again, very similar results to what we saw in ZUMA-7. The complete response rates in the lysocell arm were 66% versus only 39% in the standard of care arm. This is progression-free survival. Again, even looking at 12-month data, that is 52% in the lysocell arm compared to 33.9% in the standard of care arm. So significant improvement in PFS. Median PFS in the lisocabtagene, the lysocell arm, was 14.8 months versus only 5.7 months in the standard of care arm, which was the transplant arm. You know, this is overall survival. Median overall survival was not reached in the lysocell arm, and it was 16.4 months in the standard of care arm. The third phase 3 study was Belinda, which this is Kymriah, basically, the autologous CD19 CAR T-cell therapy. And this is the study design. Patients were leukapheresed at screening. They did receive optional bridging with a platinum-based chemotherapy. The standard of care arm received salvage rice or RDAP investigators choice. They then underwent a week 6 PET scan, and then they received either tisagenlecleucel or standard of care. Now, the difference here being that patients who did not achieve a complete remission actually ended up receiving multiple lines of platinum-based therapy, and including a different platinum-based therapy altogether. So they may have had 2 or 3 different salvage regimens here by the time they actually made it to stem cell transplant. And the fact that they looked at this, they based a lot of the criteria for non-response on the week 6 assessment actually did affect the outcomes, as I will show you. So the patient characteristics were relatively equally distributed between the 2 arms. The median time from initial diagnosis to randomization was similar, about 8 months in both groups. And the median time from the most recent relapse or progression to randomization was about 1.4 months in the tisagenlecleucel and 1.1 months in the standard of care arm. So if you look now at what patients received, you can see that in the tisagenlecleucel arm, almost 50% of patients received more than 1 cycle of chemotherapy prior to their lymphodepletion. And then in the standard of care arm, 97% of patients received multiple cycles of chemotherapy. And importantly, the median time to the actual infusion of the T cells in the tisagenlecleucel arm was extremely long at 52 days. And even in the United States was 41 days, but particularly in Europe was longer at 57 days. So surprisingly, when they looked at the event-free survival, which was their primary endpoint, that was actually disappointingly the same in both the tisagenlecleucel and standard of care arm. Why did this happen? I mean, why was this study different from the prior 2? When you look at the week 6 assessment that they did after these patients received bridging therapy or salvage chemotherapy, you can see that in the tisagenlecleucel arm, 26% of patients actually had progressive disease, compared to 14% in the standard of care arm. So they progressed before they were able to receive the lymphodepleting regimen and CAR-T. So the investigators for the study did point that out, that the progressive disease at week 6 was more frequent in patients in the tisagenlecleucel arm versus the standard of care. There were multiple meetings, and experts in the field were asked about why they thought that Belinda failed to show an improvement in event-free survival. And there are several factors for this that I'm sure will guide the development of future trials for them. So the first was the long time to infusion with Kymriah in Belinda, 52 days compared to 29 days with Yescarta in ZUMA-7. Belinda allowed multiple lines of chemotherapy as bridging therapy, which was different from ZUMA-7 and Transform. Belinda also used lower dosing of lymphodepleting agents, which are important to obtain disease control in these patients that are not as heavily pretreated, right? Because these patients had only received 1 prior line of therapy. So in Belinda, Cytoxan was only 900 milligram per meter squared over 3 days, and fludarabine was 75 per meter squared, whereas the other 2 trials had a higher Cytoxan dose of 1,500 milligrams and 90 milligrams per meter squared of fludarabine over 3 days. There were some differences in disease criteria. So ZUMA-7, for example, enrolled only diffuse large B-cell lymphoma patients, whereas Transform and Belinda allowed patients with 3B follicular lymphoma, which one could argue may be less aggressive. And the Belinda trial's definition of event-free survival actually counts failure to achieve a response at the week 12 assessment as a negative incident. But due to the long gap to treatment, some patients did not adequately respond to Kymriah at that point, and they responded to Kymriah after the 12-week mark without any additional therapy. So several factors for why it failed. So what is Novartis going to do? Are they going to pursue another trial using the same product, trying to mimic the other two studies? They have moved away from that. They have moved on. And what they actually announced was this a next generation platform that's called T-Charge that aims to revolutionize CAR T-cell therapy. And what it does is that it preserves T-cell stemness, the ability to self-renew and mature, that results in a product that has greater proliferative potential and fewer exhausted T-cells. And they already presented at ASH now data from 2 first-in-human dose escalation trials, so YTB323 in lymphoma and PHE885 in multiple myeloma. So there were 2 scientific posters that went along with the first-in-human clinical trials, and what they basically showed is that this T-cell T-charge manufacturing process actually gives a product that retains the immunophenotype of the input leukapheresis material, where naive and central memory cells that are CD45 RO negative and CCR7 positive are actually preserved, as you see here. I don't know if you can see this here on the right, as opposed to the traditional manufacturing approaches where the cells are CD45 RO positive, CCR7 negative. So the thought is that these cells, this is the time will reduce the manufacturing time basically to less than 2 days, because these cells are going to be able to go into the patient and expand and proliferate in vivo. So when you look, again, these are called Violin plots. There is the YTB323 CAR T cells here actually showed very similar central memory T cell phenotype and stemness gene signatures as the input material here in red, compared to the standard autologous CD19 product, where there's more of a T effector memory phenotype. And the stemness high signature is retained in the new product YTB323 versus low stemness signature in the conventional autologous product. And what this did is that it actually, when they looked at a tumor model, it showed better in vivo anti-tumor efficacy. This is traditional manufacturing, and this is the T-Charge platform, where you can see that even as low of a dose as 0.1 times 10 to the 6, here shown in blue, gives a response compared to 0.5 times 10 to the 6 in the traditional manufacturing. So fewer cells are actually, CAR T cells are required for tumor suppression. And even when they looked at the expansion, that they looked at in the blood by flow cytometry, these cells were very potent, and they actually had much better expansion. So their Cmax was 40 times higher, and AUC in the first 21 days was 33 times higher for YTB323 as compared to their traditional manufacturing. So this is what they used in the first-in-human study in patients with relapsed diffuse large B-cell lymphoma, and they saw some very encouraging data. They had 2 dose levels, and they treated about 20 patients, 15 patients who received this product at dose level 2, they had a very high complete response rate of 73%. And they didn't, importantly also, they didn't see any safety signals beyond what was known and expected with Kymriah. So I think that all of the future studies that we're going to see coming out of Novartis will be utilizing this platform. And at some point, they will probably compare this to the standard of care, which is autologous stem cell transplant. And this eventually, I think, will replace Kymriah. So just to shift gears quickly towards multiple myeloma, as you know, BCMA is highly expressed on malignant plasma cells in multiple myeloma, and then higher concentrations of soluble BCMA are associated with poor outcomes. And that's why this presented a very rational target for therapy. There's a lot of competition in terms of antibody drug conjugates and bispecific antibodies. But in terms of CAR T-cell therapies, the advantage is that hopefully it's a one and done deal if you have a good product and you don't have to continuously infuse antibodies. So currently, idacaptogene viclucil and ciltacabtagene autoleucel are both approved in patients who've had 4 lines of therapy, exposures to immunomodulatory agent, proteasome inhibitors, and also anti-CD38 monoclonal antibody like daratumumab. So this is the phase 1/2 data with BCMA-directed CAR T-cells in multiple myeloma. So BB2121 was the first product approved. You see it has a 73% overall response rate, a 31% complete response rate in a heavily pretreated patient population. However, disappointingly, the median progression-free survival was only about a year. And so people realized very early that something else needed to be done and that we need to improve upon this product. So LCAR-B38M is a CAR construct that actually has SCV targeting 2 BCMA epitopes instead of 1. So it targets both VHH1 and VHH2. And when they looked at the data, the overall response rate was 100% with complete response rate of 76%. And there's also another product where, which is fully humanized, and that's enriched for early memory phenotype. So this kind of kills 2 birds with 1 stone. The cells hopefully persist longer, but because of their early memory phenotype, but also in being fully humanized, there is less development of antibodies that result in destruction of these CAR T cells. So CARTITUDE-1 was a phase 1b/2 study of ciltacabtagene autoleucel, and they presented at ASH their 2-year update. And this is very similar in terms of leukapheresis, lymphodepletion with fludarabine Cytoxan, and then they had the cilta-cel infusion. The baseline characteristics, just important to note that 87% of patients were triple class refractory and 42% were penta-drug refractory, so very heavily pretreated and resistant patient population. When you look at their overall response rates, I mean, dramatic, 97.9%. And when you look at stringent complete response, extremely high, 82.5%. The median time to first response was quick, a month, and median time to CR or better was 2.9 months. The percentage of patients that are remaining progression-free at 2 years was 60.5%. So that was better than what we saw with idacaptogene. And you can see that this is important because basically for 2 years, these patients did not get any other therapies, which is important in terms of quality of life and preservation of organ function. So when we look at PFS and overall survival, the 2-year PFS was 71%, median PFS not reached, compared to 60.5% here in blue for patients who, the all-comers compared to patients who achieved stringent CR that did significantly better in terms of progression-free survival at 2 years. So that's what denoted here in blue, and as expected, the stringent CR patients would have better outcomes. And if you look at progression-free and overall survival by MRD status, again, significantly better in patients who were MRD negative, and MRD negativity. Negative patients actually maintain their progression-free survival beyond a year. I'm going to switch gears now finally to ALL briefly, but importantly, we now do not have just the tisagenlecleucel approval for ALL up to 25 years old. We also have brexucabtagene autoleucel recently approved in adults with relapsed refractory B-cell ALL, a much anticipated approval. So Ileana was in children and young adults, showing a significant improvement in event-free and overall survival with tisagenlecleucel in this patient population, including patients who did not go on to receive an allogeneic stem cell transplant. And this is ZUMA-3 with brexucabtagene that showed 70.9% CR or CR with incomplete hematologic response, pretty high in adults with relapsed refractory ALL. So this has already previously been published, but to point out what was interesting at ASH is that patients are relapsing mainly because they're losing CD19. And so a lot of effort has gone into finding ways to mitigate that risk. So either by giving dual CARs like CD19/22, giving off-the-shelf CAR products, or by reinfusing CAR T cells in patients who may be at high risk of relapse. And so this was a study from CHOP at UPenn in children and young adults with relapsed refractory ALL. And they basically followed patients from the time of their first CD19 CAR T, and if they were minimal residual disease positive, if they relapsed, or if they saw that they had early B-cell recovery and or CD19 hematogones in the bone marrow, they basically reinfused them with the autologous CAR T cell products within 6 months of their initial treatment. And you can see that in patients who were reinfused because of hematogones, actually the majority of them, 76%, achieved a complete remission. And also patients who had early B-cell recovery but did not have measurable disease, a good proportion of them achieved CR without needing consolidation with a transplant. However, patients who were reinfused for non-response, actually all of them pretty much did not respond to the CAR T product. So the clinical implications for this are that CAR T cell reinfusions can prolong B-cell aplasia in a subset of patients with short CAR persistence, and this can reduce risk of relapse. Reinfusions can induce remission in patients with prior relapse, but the remissions have limited durability. And really, it does not make sense to reinfuse patients who were refractory the first time around because none of them actually responded. So this is just the class effects of the immune responses, CRS and neurologic toxicity. You see that they're very, very variable amongst the products in terms of both CRS and neurologic toxicity. And so the less disease burden patients have at the time of treatment, the better the outcomes and the less toxicity. And this is a lesson that we've learned. So the studies now are moving to incorporate these therapies earlier in the disease course, or to debulk the patients before we actually give them the products. And I think that's all I have. So what I'm going to do is I'm going to pass it over to Lohith, and then we'll do questions at the end.
Thank you, guys. Can you hear me?
Yep.
Okay, thanks. Good afternoon, everyone, and I just thank you for that beautiful presentation. That really indeed is transformative. Here are our acknowledgements. These are the people who have led the studies that I'm going to be presenting. Most of them have shared their slides. I'm grateful for that. Objectives of our talk today would be to mainly look into the therapeutic avenues in which allogeneic stem cell transplant has been making progress in order to reduce some of the complications associated with it, which ultimately results in a better curative promise on the quality of life. I'm going to present a trial wherein we're going to use ruxolitinib pre and post transplant, and I'll present some data from University of Minnesota that looked into uh, human chorionic gonadotropin in addition to standard immunosuppression for patients with acute GvHD. I'll also present two phase 2 trials looking at chronic GvHD targeting different pathways. This was a trial that was led at MGH, but it was a multi-site study led by Dr. Hobson team. Basically, the study is looking into use of ruxolitinib, which is a JAK inhibitor, prior to, during, and after stem cell transplantation for patients with primary or secondary myelofibrosis. So for those of you who manage myelofibrosis, this is a very common slide. The disease can be classified into 5 different categories. Things on the left here usually get managed conservatively or using cytokines and things. For symptomatic splenomegaly patients, we use ruxolitinib, and more recently this drug has been approved. Once they start coming to intermediate risk or have bad gene signatures or have high or very high risk groups, those are the people, if they're eligible for transplant, they'll be considered for stem cell transplantation or clinical trials. This is just a slide that shows that for the groups here, starting from gray, yellow, and blue, the median overall survival is less. Those are the people that are normally considered for stem cell transplantation based on clinical scenarios. So why is it that stem cell transplantation, although being curative, has been a little bit of a problem for us? Well, most of these patients who have a bone marrow fibrotic condition have splenomegaly, and patients who come in with splenomegaly at the time of transplantation generally tend to do poorly compared to others. You can consider options to take out a spleen, do radiation surgery and things like that, but it has its own infectious risk, thrombotic risk, which ultimately decreases the promise of transplant. In addition, we've seen people have poor graft function. Graft failure rates can be up to 15%. That adds up to the non-relapse mortality. And there are some trials which reports pretty high rates of GvHD and non-relapse mortality for myelofibrosis compared to other people. The real question is if ruxolitinib and the rest of the drugs which are now making foray into the field of myelofibrosis, is it possible to continue these drugs in a longer term? Because, as I said, Jakafi has implications on symptomatic control for people who have myelofibrosis, can decrease the spleen size. Over the last couple of years, we've learned that this drug is pretty active in both acute and chronic GvHD. Now we have a label for it. If people have been on Jakafi and you stop it prior to transplantation, there are some reports which suggest that it can manifest as cytokine release syndrome kind of clinical spectrum, and there have been efforts to see if this drug can be continued. And there are also people who think if you suddenly stop it, will the spleen rebound or bounce back and things like that, which ultimately has negative impact. So the real question this study is trying to answer is it safe, effective to use the drug pre and post-transplantation? This is the study schema. It included patients with myelofibrosis, both primary and secondary. Pre-transplantation, they would start the drug at 5 milligrams, which is a lower dose around day minus 14, continue it with conditioning regimen, use it in the post-transplant period, reevaluate the patients at day 30 post-transplantation, at which time, if the counts have recovered, we bump them up to the 10 milligrams BID dose, which is what we kind of use it in our GvHD setting. So the key inclusions were mainly adult patient population, as I said, both primary and secondary. This is a classification system. This is a DIP system. If that intermediate 1 risk group, in addition to adverse molecular markers, or people greater than intermediate 2 were included. They went with reduced intensity regimen. As we see, its melphalan was 140 or lesser dose. Commonly used regimen prophylaxis of methotrexate and tacrolimus was applied in the setting. Here is some characteristics. I know it's a busy slide, but all that I want you to focus on is that most of these people, about 85% of the people on this trial had a splenomegaly coming in. The study largely consisted of matched, related, and unrelated donors. The number of mismatched donors was less. The first thing that you think about when putting ruxolitinib in the post-transplant period is how is the engraftment. This is a pretty myelotoxic drug. People can have deep cytopenias. And here's a report. At day 30, 23 out of the 24 patients had engrafted ANCs. and the platelet count tend to lag behind a little bit. Whether it's the drug, whether it's the spleen, it's debatable. You follow them up to day 60, neutrophils have recovered, but the platelet still lags behind. By around a little more than 100 days, almost everybody recovers their platelet count. And here are the clinical outcomes that are reported. The 1-year OS is about 77%. The 1-year cumulative incidence of relapse is around 17%. 1-year incidence of chronic GvHD is 14%. I think it's also important that the 6 months incidence of grade 3 to 4 acute GvHD, which can be lethal, it's about 4%, was kind of impressive. So based on this trial now, people are starting to contemplate to see, yes, this drug has benefits in pre and post-transplantation setting. In some of the high-risk patient population, maybe this can be translated into clinical use. We will now switch gears and go to an acute graft-versus host disease study that is presented by Minnesota group. This was a phase 2 study. A couple of years ago, they presented their phase 1 data that was published in Blood Advances. Dr. Holton and et al. Had led this study. Basically, the rationale behind using human chorionic gonadotropin and epithelial growth factor is that acute GvHD, when it happens, it's usually in the setting of an immune attack due to the discordance between the recipient and the host. Commonest therapeutic interventions that we apply are all deeply immunosuppressive. But by the time the immune cells have caused on destruction to the epithelial lining, in the absence of anything else, we continue to escalate immunosuppression. But here they're trying to come up with the concept of using tissue repair mechanisms by using growth factor support mechanisms like epidermal growth factors. We've also known, the concept of pregnancy, we've all known that, HCG is kind of tolerizing, immune tolerizing. It increases T regulatory population compared to conventional T cell population. It also has impact on anabolic sides of metabolism. And as I said, EGF also decreases amphiregulin, which is kind of being thought as a marker of inflammation in addition to promoting epithelial healing. More and more T cell metabolic studies suggest that butyrate seems to promote Treg expansion, which is a kind of a thing we like in the field of transplantation, unlike neoplasms where Tregs are not well liked upon, but to develop tolerance, we like any agents that increases Treg population. So based on their phase 1 design, they now were, they identified 2,000 units as the appropriate dose. And they included 2 risk groups, the Minnesota high risk group and the second line therapeutic group. I can give you references for this at a little later stage. They will use the drug sub-Q every other day for 7 days, in addition to the high-dose steroids, which is the commonest first-line agent we use. For the second-line cohort, they would use this combination, the same dose, sub-Q, or if you were going to use it at 5,000 units for those who are steroid refractory, it was given every other day for 14 days, in addition to the standard of care. And that standard of care was left to the physicians based on their choice. This is just a brief synopsis of what were the cohorts like. Largely, I wanted to focus on the fact that in the first line cohort, most of those people were stage 3 to 4 lower GI GvHD, which is what is more challenging to manage. In the second line cohort, they did have a few skin cases that were stage 3 or 4. They have some pictures in their presentation. I'm not showing that, but they were pretty bad skin GvHDs. But regardless, most of them had a grade 3 to 4 acute GvHD, which is kind of challenging to manage. Here are the response rates. In the acute GvHD clinical drug development, 28-day response has been kind of validated as a nice marker to predict responses. So at day 28, for all patient cohorts, there was a 57% CR and 11% had partial responses. For the high-risk Minnesota risk group, the CR rate was 64%. In the second line, it was 50% CR rates. And here's the non-relapse mortality. GvHD can easily lead to that. This is for the entire cohort. In the dark lines for the high-risk group, and this is for the second-line group. The p-value was not significant, but based on those who are responding, CR or PR versus non-responding, there seems to be a trend that the non-relapse mortality at 2 years is declining with this intervention. And here's the same analysis for overall survival based on the whole cohort, and this is for those who are responding based on this kind of response we elicit with this intervention. When they presented the causes of that, it's still interesting that GvHD happens to be still the commonest cause of death, right? About half of the patients that died with a median follow-up of 17 months. Relapse is the second most common stuff, and infections and organ damage, which we commonly worry on that, didn't seem to be that much, but again, it's a small patient population. In summary, I think they show that the response rate of 68% is pretty reasonably accepted at day 28 and doesn't significantly impact non-relapse mortality. Based on the fact that people are still dying with GvHD and relapses, they're recommending either using biomarkers, and they have some nice profile of metabolic stuff that they've reported, which I can talk to you later on. But it's kind of a novel development in the field that we don't necessarily have to keep thinking about escalating immunosuppression, but now we need to start focusing on getting the right immunomodulation in addition to tissue repair pathway drugs. In the other half of the talk, I'm going to talk about chronic GvHD. For some of us who do this on a daily basis, we see this in up to about 50% of patient population. Use of post-transplant cyclophosphamide has brought that number down, but most people don't get it because cyclophosphamide does have some issues in terms of infection, cardiac toxicity, and other things. And again, it's largely applied in the setting of unrelated donors, not commonly used in matched sibling donor transplantation. For those who develop chronic GvHD, steroids has been the workhorse for multiple decades. About half of those patients eventually need second-line treatment for disease progression, and they don't tend to do well at that stage. Up until a year and a half ago, we really didn't have that many drugs. Ibrutinib was approved a few years ago based on this trial. It's a BTK inhibitor, as you all know. The overall response rate was about 67%. CR was 21% in that. In the last 12 to 24 months, now we have two drugs. Belumosudil, which is a ROCK2 inhibition. This not only has anti-inflammatory properties, but it also kind of targets the scarring part of it, which is kind of a novel mechanisms. Here, the ORR rate was about 73%. And the CR rate, despite being low, the PR was high. But based on the fact that it targets the scarring pathway, it's been approved recently in addition to controlling GvHD. I spoke to you earlier on, ruxolitinib approved for acute GvHD. In the last 6 months, it's also been approved for chronic GvHD. Again, the rates of CR is close to about 50%. Most of these drugs are approved for people who failed at least 2 or more lines of therapy, but these lines of response rate suggest there is still more that's needed to optimize this field. One of the areas which is kind of not that commonly explored, but is a welcome change, is commonly we think about GvHD as a T-cell mediated pathway. This work that was presented by Stephanie Lee's group from Fred Hutch is now looking into targeting macrophage-driven chronic GvHD pathophysiology. Colony stimulating factor 1 receptor-mediated pathways. Once the monocytes circulate in, they can get into the tissues, and then they can differentiate in either into M1 or M2 phenotypes of macrophages, which the M1 being pro-inflammatory, this being anti-inflammatory. But now people are looking into developing drugs against this, which promotes this differentiation to decrease the inflammation. And the drug that I'm going to talk to you is a C colony stimulating factor 1 receptor antibody. Inhibition of that is thought to decrease fibrosis and bring about changes in collagen structure, which kind of then has impact on tissue healing for people with chronic GvHD. The drug is axatilimab. As I said, it's a humanized IgG4 monoclonal antibody, binds to CSF1 receptor. In addition, it also binds to IL-34, which has inflammatory properties in the skin. It's administered over 30 minutes for every 2 to 4 weeks. It's highly effective in decreasing the fibrotic signals and the non-classical monocytes in addition. Using this intermittent dosing pathway, they found that it gives opportunities to keep the drugs going frequently because the cells do recover in the meantime. This was a phase 1-2 study design. They wanted to test in the phase 1 about 17 patients, 0.15, 0.5, 1, given over Q4 weeks or Q2 weeks. And then they went to the phase expansion at 1 milligram per kilogram. That included a larger number of patient population. Presented here is the baseline characteristics for patients. A quick summary of this is that most of these people were heavily treated. That more than half of the people in both the phase 1 and 2 had 4 or more organs involved, consistent with modern practice. People had been exposed to Ibrutinib, ruxolitinib, and belumosudil, which is a ROCK inhibitor that I showed. And they basically show that there's no differences between the enrolled patient populations. And the drug seems to be pretty well tolerated across both groups. The discontinuation rate, although seems to be high, but in this context, it's pretty challenging. And about 30% in the phase 1 and about 58% are still continuing this drug in the phase 2 arm. More interestingly is the response rate. most of the responses, if we do show the responses, especially with this 1 milligram per kg Q2 weeks, the responses seems to be pretty durable. And same is the case with 3 milligrams per kg. And when you look around their best overall response rates and time to responses, that's reasonably impressive. But time to response of, in 1 month is something that you don't often see, and that's a welcome change. The next question people commonly ask is, how about organ-specific responses? Well, light gray or bluish is the CR rates, and the dark one is the PR. Lower GI, everybody seems to have good responses. What's of interest to us is the joints and the skin, which here seems to be PR based on its antifibrotic mechanisms. People ask me what happens to the lung, which is more common and challenging to handle. Seems like, at least 5 out of 15 patients is a reasonable one for CR when it has the lung. And about 80% had severe skin sclerosis at baseline, close to 16% had improvement in sclerosis. Another aspect that we tend to ignore is you might have clinical manifestation, but what about the quality of life and symptom burden? And here's just a graph in summary that's depicting that across the dose group, people had good responses in the symptom scale. In conclusion, I think the investigators were able to show that targeting monocyte macrophage pathway, the CSF1 receptor ligand, seems to be meaningful, leads to decent response rates. Sclerosis seems to go down on it. Now there's a trial that they're going to randomize different doses, potentially as a group we're contemplating participating in this thing, but it's kind of opened up the concept of targeting monocyte macrophages in addition to the T cell thing that we commonly pursued in chronic GvHD. And the last study that I'm going to talk about is Ibrutinib. This was a study that was done at Boston. Ibrutinib, as you all know, is a T cell co-stimulation modulator. The T cell receptors, after recognizing the APCs, would interact with the MHCs, and the CD20 would normally interact with the CD18 and 86. This is necessary for T cell activation, proliferation, and production of inflammatory mediators. Whereas Ibrutinib inhibits this pathway by targeting CD80 and 86, and this co-stimulation doesn't happen. And the hypothesis here is that if you somehow can prevent this T cell co-stimulation, maybe the proliferation activation doesn't happen. That leads to decreased chronic GvHD. About 6 months ago, and I know I'm using the 6 months to 1 year commonly because that's how frequently the drugs are getting approved in this space recently. The drug was actually approved for prevention of acute GvHD, mainly for unrelated donors. So this is a study in the backdrop of that, but obviously the context is in a chronic GvHD context. So people are wanting to see, yes, this is a drug that's now going to be commonly used. What happens in the chronic GvHD setting? So the design was this: close to 40 patients who had both ablative and reduced intensity transplants had declared themselves steroid refractory, and the definition of that was persistent signs and symptoms of chronic GvHD despite use of steroids, 0.5 mg per kg per day for at least 4 weeks. They were to be getting this dose, 10 mg per kg, which is what the acute GvHD dose was, every 2 weeks for 3 doses. And then they would go on to get it for every 4 weeks for 3 doses. Based on the clinical response, there was no response that would come off. If there a clinical response, further continuation was allowed. The aim was to look into the rates of overall response rates and see how things were playing out. And this is just a description of how things go on. The overall response rate was 49%. Unfortunately, CR was 0, and most of them were PR responses. This is just a spread across different organs. In the interest of time, I'm going to quit that. And this is a slide that basically shows, while you look at response rates, it's important. Steroid has been the main drug that we've used. Quite a few of our people were able to decrease down their dose of steroids, which has long-term implications on their metabolic health, mental health, cardiovascular risk, and things like that. So with that, the investigators conclude now a 50% objective response rate, ORR, in the steroid refractory is a welcome change. Importantly, there was a durable reduction in prednisone dosing over time. Infections were uncommon in this context, and infusions were pretty well tolerated. There are ongoing studies for correlates and biomarkers and things like that. With that, I'll end the talk and thank everybody for coming, and I'll open it up for the audience.
So we're going to open this up to questions now. You can feel free to ask them or write them down in the chat for each of the talks. And maybe in the meantime, I'll just ask Lohith, Lohith, do you think that given the good efficacy we've seen with ruxolitinib in patients with steroid refractory Gvhd, do you think that there's, and given the what seems to be fairly good safety profile of the human chorionic gonadotropin, do you see a role for the combination of that with ruxolitinib? And in terms of steroid sparing effects in this patient population? I don't know if there is such a trial that's already been, that University of Minnesota is doing or not, but that would seem like a reasonable trial to conduct.
I think that's a great question, Alice. Obviously, the CR rate's around 60 to 70% based on which trial you look around it, the ORR response rate. The real question is, the day 28 is the magic bullet, at least in most trials. How much are we going to myelosuppress? The good thing about this drug is it's not deeply myelosuppressive, right? I think that's a great part of this. There's always been this concern in the field that if the inflammation kicks in and the tissue is wiped out, you're in a losing cause. That combination makes rational sense, but I'm not certain the group is pursuing this. Clearly, I think what it's showing is we just probably need to start thinking and de-escalating immunosuppression sooner rather than keep harping on it, which is what we've done for many decades. Hopefully, we'll get a good anti-motility drugs, good tissue healing drugs going forwards, and this seems to be the right start.
There's a question in the chat about the mechanism of ROCK2 and ROCK2 inhibition. Can you tell us a little more about that?
Yeah. So I think it's Mass General and Dana-Farber. A few years ago, they came up with this idea that, just like most things, we have anti-inflammatory drugs, but we don't really have good anti-fibrotic drugs. And I think this ROCK pathway has been shown in systemic sclerosis and at least in the scleromatous GVHD mouse models. Targeting ROCK pathway, ROCK2, results in decreased scarring, decreased fibrosis, and that was the rationale for that. Considering most of chronic GVHD people have facial involvement, synovitis, myositis, and things, there's a lot of interest that's going on. A couple of our dermatology colleagues are now banking the samples, at least my patients, trying to address what are the synergistic things that we could use in addition to the ROCK pathway that further suppresses fibrotic mechanisms. Because rarely we do see them, some of them come up with contracted arms and things like that, and that has functional implications. More importantly, it's not deeply immunosuppressive, and that's a welcome change. The rates of infections are low, and here and there, this is something that you hear in the KRS say, oh, I've seen good responses even in lung GVHD, but I think as a special cohort, I would like to see a little more to see if that brings upon field-changing shift, but that's still a work in progress.
There's also a question for Iris about immune approaches post-CAR T to enhance retention of cells for continued response. I think you touched on that a little bit with that new Novartis platform, but people doing other things, try and get CAR T cells to persist or work better afterwards that you heard of?
Yeah, well, I mean, so the humanizing CAR T is one approach to for them to persist better. Again, looking at the central memory phenotype, so using enriching for that particular patient population is another approach to enhance retention. The other thing is that they do have these CAR Ts that secrete cytokines, so that's another approach. And in fact, there was actually an abstract at ASH that I didn't show, but I have a slide of with a BCMA therapy releasing, with a BCMA CAR T releasing cytokines that enhance proliferation. So there are multiple approaches, and actually, sometimes that can be a double-edged sword, right? Because these cells can proliferate very rapidly, and then you have to think about a switch to turn them off, because they can become very toxic. But you can combine them. You can do basically like Sidi Chen is doing at Yale, a dual knock-in, knockout, where you can knock out PD-1. So I mean, that's another approach, right? So looking at the microenvironment, can we actually get cells that are less exhausted by affecting the microenvironment? For example, those efforts are going on in CLL, where there is a real problem with persistence of these CAR T cells. So those are all, the other thing is CAR T cells, like one of the labs is doing here with Shale Su, with targeting low antigen density, for example, T cells. So that's another approach, so that once they may progress after regular CAR T, or if you see decreased antigen expression, is to actually target them with a CAR T that has higher avidity. So those are some of the approaches to enhance the retention of these cells and continued response.
So I have one question for you, Iris, that it has come up, and there's already been a trial, but given the favorable results, at least from the ZUMA-7 trial, do you foresee a time when CAR T are used even in high-risk patients as part of their initial therapy, as opposed to waiting for disease refractoriness or relapse?
I mean, different from the ZUMA-12. So ZUMA-12, for example, right, they took really high-risk patients and they stratified them by PET after 2 cycles. And patients that were PET positive went on to get CAR T. And the outcomes were pretty good. The problem is, I think we need to get a little bit longer follow-up because, patients who have a positive PET scan after 2 cycles, may still go on to achieve complete remission at the end of 6 cycles of therapy. So I don't know if it's ever going to make it to frontline. It may. It's not. We're not there yet. I think that what companies are doing now, though, they are sponsoring trials where they pay for the collection of T cells early on in somebody's presentation, and they save them in the event that patients do relapse. And they will probably sell those to pharmaceutical companies that are designing trials.
Right, that's interesting.
Yeah. So that's going on, because I think it's really important to collect the cells as early as possible when they're fit, before people have a lot of chemotherapy. So there may, the FDA hasn't even approved yet, right? They haven't even approved Axicell or Lysocell based on the ZUMA-7 and Transform results. I think that's the next step, because I think it should be approved, because clearly there's a PFS benefit in that patient population over transplant. So I think that's going to be probably the first approval. And then after that, we're looking at, potentially incorporating it in people with double-hit lymphomas or primary refractory disease, incorporating it early on.
All right, well, we're a few minutes after the hour, so great presentations, great questions and discussion. Thanks, everybody. Have a good weekend.
Thank you, everyone.